Listen now to a talk Noel Barry-Mertz had with Dr. Piotr Ponikowski, Chief of Cardiology at the Wrocław Medical University in Poland. They cover effects of ferric carboxymaltose on functional capacity in heart failure patients with iron deficiency.
Welcome, Piotr.
Thank you for the invitation.
So I understand this is a late-breaking trial here, very wonderful and so exciting that something simple and practical can make such a meaningful difference in heart failure patients' lives, something that we can apply as treating cardiologists. So can you tell us a bit about the design of your trial?
There was a randomized, double-blind, placebo-controlled study. We randomized our heart failure patients, stable, ambulatory, symptomatic heart failure patients, NIHA class 2 and 3, with ejection fraction below 45%. And to ensure the diagnosis of heart failure, we also wanted them to have elevated natriuretic peptides into the treatment either with the active compound, ferric carboxymaltose, or placebo. Perhaps I need to say that these patients needed to have iron deficiency, which the definition we base on a simple biomarkers everybody can assess in his or her clinical practice, namely low ferritin level below 100. If ferritin was between 100 to 300, we requested transferrin saturation to be below 20%. We
Iron
didn't
binding.
have, yes, indeed, iron binding. We did not have the lower cut level for hemoglobin.
Okay.
We only excluded patients who needed to have transfusions.
They were so sick.
Absolutely. However, we had the upper limit for hemoglobin, which was 15.
Okay. And on average, about half, I think, of your patients were actually anemic, but
Yes,
many were not.
Yes, it is a very good point indeed, because obviously we pre-specified criteria for anemia. So we used a common approach and said, okay, hemoglobin below 12 is when we decide to label them as anemic. However, half of our patients did not have anemia, which is extremely important because everyone, or most of us, intuitively are linking iron deficiency with anemia, which is not the case in heart failure.
Exactly.
Over the last years, we have convincingly proven that iron deficiency is very frequent comorbidity in heart failure, regardless of anemia.
Yes.
More than 50% of patients are affected. So we need to keep this in mind. So this is not anemia, this is iron deficiency in anemia and not necessarily in anemia.
And your patient population was a general heart failure population. These were not highly specific other than being iron deficient.
Indeed, I think our population reflects what we are treating in Europe, very everyday population of patients with heart failure. NIHA class 2-3, low ejection fraction, optimized therapy. And this is perhaps very important because we made sure that our patients are optimally pharmacologically managed. Virtually everybody receiving beta blocker, angiotensin converting enzyme inhibitor, ACE inhibitor, and aldosterone antagonist. So well-treated people.
Exactly. So well treated from a cardiologic standpoint, but perhaps a general medical problem that was not being addressed. So what did you find?
Primary endpoint of the trial was change in 6-minute walking test at week 24. However, we prospectively designed several secondary endpoints, some of which included the assessment of functional capacity, exercise capacity, quality of life with a standard methodology. And on the top of it, we prospectively decided that we also would investigate the outcome, namely death and hospitalization. These endpoints were collected throughout the whole study and most importantly evaluated by the endpoint committee, independent, blinded endpoint committee throughout the trial.
And your results were?
The results were the treatment with ferric carboxymaltose significantly improved 6-minute walking test distance at week 24. So in other words, the primary endpoint was met.
And fairly dramatically.
And it was really indeed. I
clinically.
like you use this dramatically improved because I am biased being a PI of the trial. But it was really clinically meaningful and robust result.
Yeah.
The treatment effect was 33 meters at week 24. And to put this into clinical context, we have seen that sort of magnitude of improvement only with cardiac resynchronization therapy. So clear, primary endpoint met, but also secondary endpoints, if we refer to them, virtually all secondary clinical endpoints related to quality of life, functional capacity, exercise tolerance were improved. And perhaps the most important issue is that was a sustainable effect, detectable very early and seen at the end of 1 year follow-up. Very important. We didn't have such data. Before we started, we didn't have a long-term data regarding the efficacy and safety. And regarding the outcome data, we observed significant reduction. There was no difference in death, however, significant reduction by 70% in the risk of rehospitalization for heart failure.
And this is a particularly contentious point in the U.S. today because of our new guidelines and penalties for rehospitalization for heart failure within 30 days. So this will be very important to the U.S. and all of the cardiologists taking care of heart failure patients. Tell us, why didn't you use oral iron? Why using IV iron?
So again, intuitively, it looks like oral iron should be a preferable choice. Looks like simple, easy, no problem. But first of all, we learned that in the magnitude of iron we need to replete, which on average is between 1,000 to 1,500 milligrams. We learned this from the previous trials. You would need around 500 consecutive days of oral iron repletion because you simply cannot digest and absorb more than 3 milligrams per day.
Yeah.
So you need 1.5 years.
Yeah,
on
it
average,
just takes too long.
which is theoretically possible, but unlikely in clinical practice, taking into account that this oral iron gives you a lot of intolerance.
Yeah, the
so
GI
very,
problems.
very few people would tolerate that kind of a treatment for more than 1 year.
Did you find that tolerance of the IV iron was just fine? Your risk and safety monitoring committee said no problem.
Throughout the study, we did not see any problems at all. Again, many of us had that sort of a history of bad side effects from the past related to IV iron, may be a little bit worried. Now the compounds which are available on the market are completely different.
Very
and
safe.
it is also very safe and very well tolerated. And also for us, cardiologists, who are not really using it, it was a quite new and a good experience. But we learned a lot, safe, well tolerated, and the incidence of adverse events between placebo and active treatment, virtually there was no
The same,
difference. Yeah.
yes. And I think in the U.S., we've become very comfortable with our cancer patients seeing the hematologist for blood agents and IV iron when it's not working. So I think that's a good experience. What implications would you say this new, exciting clinical trial has for the practicing cardiologist?
Well, I'm very glad that you're always directing me to everyday clinical practice, because what we are doing is always, at some stage, the sooner the better, needs to be translated into clinical practice. So, few comments. First, we have the evidence, and this is a growing evidence, and every year, I would say, we have stronger and stronger message. Actively seek for iron deficiency in heart failure patients.
But test ferritin
And yes,
iron
and we
binding.
and we have a simple biomarkers. We may debate whether this is 100% accurate, but nothing is 100% accurate in a simple clinical practice. We need to have some simple tools.
These are easy
So number
tools.
one, if you have this, again, do not link iron deficiency with anemia. So take into consideration that your iron deficient patient may not necessarily be anemic. So also in those with hemoglobin between, say, 12 to 15, 16, also consider iron deficiency as a common comorbidity.
Yes.
And if you find it, treat it, because it's safe and well tolerated.
Your clinical trial has strong implications for heart failure patients. It also begs the question, because of cardiology takes care of circulatory disorders, whether or not we should be looking for this in the many other types of heart disease that we treat, angina, stable ischemic heart disease. That'll be your next trial.
Well, I think that very glad that you mentioned this. Quite recently, we published in the Diabetes Care a very nice, I would say still observational study, showing that patients with angina and diabetes, they are very prone
Also
to
iron
develop
deficient.
iron deficiency. So I'm glad that you mentioned this.
Okay, great. All right. Well, thank you for sharing this exciting clinical trial. Thank you, Piotr, and we're signing off for ACCEL.
Thank you very much for the invitation.